presented this single center head-to-head study where we had the opportunity of comparing in the real world the efficacy of hematopoietic stem cell transplantation versus two highly active disease-modifying treatment, which were Alemtuzumab and Ocrelizumab. Overall, the efficacy of hematopoietic stem cell transplantation has been extensively investigated, and it is widely recognized as a very effective treatment in MS. But it still remains unclear where to position HSCT in the treatment algorithm among the most effective treatment for MS. So real-world evidence are scarce and are needed to make a more informed decision. And we had the opportunity to compare this to Alemtuzumab first, and in both groups we could follow up patients for 5 years almost. So it was a decently good long follow-up. And what we showed was that the HSCT is by far superior than Alemtuzumab in preventing the new focal inflammatory activity, as patients in the HSCT group were much less likely during the follow-up period of experiencing new relapses, as well as new MRI activity. So there was a large and significant differences compared to the Alemtuzumab. In addition, in the HSCT group, the annualized relapse rate, which gave a rate of relapses during the follow-up period, was significantly lower compared to the Alemtuzumab, again supporting the superior efficacy in terms of preventing inflammatory activity. However, when we look at the disability outcome, we could not appreciate much differences between HSCT and Alemtuzumab, as in both groups, the similar proportion of patients experienced EDSS worsening, which in a way suggested that the superior efficacy of HSCT in preventing relapses did not translate into more significant suppression of accumulation of disability. So hinting or lending support to the well-known, now widely accepted notion that mechanisms accounting for relapses are probably different from those accounting for the accumulation of permanent severe disability. Quite interestingly, we observe a larger proportion of patients in the HSCT group experiencing disability improvement in significantly larger proportion compared to the Alemtuzumab group. So this was quite an interesting outcome measure to look at. When we then assess HSCT in comparison to Ocrelizumab, we did not see such a dramatic difference between the two compared to the analysis versus the Alemtuzumab. We observe a larger proportion of patients not remaining free of relapses compared to Ocrelizumab. However, this was not statistically significant, the difference. Although overall, the annualized relapse rate again was found to be significantly lower in the HSCT compared to the Ocrelizumab group. And we did not see any difference in terms of MRI outcome. The two compounds performed similarly, with similar proportion of patients remaining free of new MRI activity during the follow-up. It must be said that in both groups, the percentage of people experiencing MRI progression was very low anyway, which suggests a ceiling effect. So they performed both compounds very well. It must be said, and then when we look at disability outcome, again, we didn't see much difference between HSCT and Ocrelizumab. In both groups, patients accumulate disability as well as experiencing disability improvement in similar percentages. So there were some difference, but the superior effect was not as prominent as what we observed against Alemtuzumab. It must be, however, taken into consideration several methodological issues, because the Ocrelizumab group was follow-up only for 3 years, so it was a rather short follow-up. In addition, the way we prescribe Alemtuzumab and Ocrelizumab was different, because Alemtuzumab was mainly prescribed to patients with a very active form of MS, Therefore, after the therapy switch, probably they remain at risk of keep experiencing some relapses. In contrast, where the ocrelizumab is predominantly prescribed in our practice to patients with a milder disease course. Therefore, after the therapy switch, they have higher chance to achieve disease stabilization, so not experiencing any further relapse. And that's probably explained why the HSCT performs slightly differently when compared to alemtuzumab and ocrelizumab. There's also, this could also be related to the different mechanism of action. So overall, alemtuzumab is a more suitable comparator to the transplant because similarly to the transplant, they have similar induction properties in contrast to the selective B cells depleting mechanism that is from ocrelizumab. The other issue to consider is why the two, in the comparison of the two compounds, we didn't see any difference in terms of accumulating disability, which, as I was mentioning before, it probably implies that disability is driven by mechanisms that are different from relapses. And indeed, when we look at the population that was included in the analysis following the propensity score matching, we included patients who had already, by the time they were switching to the therapy, they had already accumulated quite severe disability. The baseline was EDSS was 5. So when you reach the EDSS of 5, further disability worsening is probably unrelated to relapses anyway. But these were the point of discussion. It was also important to mention that in the HSCT group, we did not observe any unexpected side effect, just the classic side of adverse reaction that are expected to be observed and in line with what was already previously reported. And most importantly, we didn't see any death related to the procedure. So overall, a safe procedure which provided high efficacy, especially in controlling inflammatory activity, in compared to highly active DMT. So of course, these findings should be extended with longer follow-up, especially for the ocrelizumab cohort.